Hello, everyone. Welcome to week 6 of the respiratory therapy program. Uh, this past week, we went over ventilator associated pneumonia, and something that was requested from week 5 was to provide another overview of Optimum PEEP. So that's what we'll plan on doing for the duration today. VAP sent you all some additional reading resource on that. Remember, it's a ventilator-associated pneumonia. Typically, it's going to occur when an individual becomes intubated and the pneumonia sets in 48 hours or more after the onset of their intratracheal endocarditis. So those are the definitions here. So 48 hours after initiation of mechanical ventilation. We also went over hospital-acquired pneumonia and then healthcare-associated pneumonia. So you want to make sure that you can review those pretty well and have a pretty good understanding of those moving forward. Additionally, we talked about ways in which we can go about preventing ventilator-associated pneumonia, whether that's using our VAP bundles or our VAP bundles, keeping the head of bed elevated at least 30 to 45 degrees, maybe the use of a continuous aspiration subglottic secretion or a CAS endotracheal tube. You may see those as a high-low evac tube, providing good oral care with chlorhexidine swabs. Uh, as we'd mentioned before, making sure we've got appropriate cuff pressures. So those are certainly things that we want to make sure that we're attentive to, because obviously if pneumonia develops, that's going to have an impact on ventilation and perfusion, and that'll also lead us into some of our optimum PEEP discussions that we're going to have here in just a little bit. Remember, taken out of the textbook, that is the some of the gram negative and gram positive aerobes that I asked you to remember, as well as the fungi, and then you can have some of the other items that could potentially lead to the onset of nosocomial pneumonias. Remember, nosocomial means that it occurred or happened while the individual was in the hospital. Uh, so make sure that you can recognize those for the purposes of exams, for your exam moving forward. Uh, but VAP wasn't all it did. We did talk about performing a bronchoalveolar lavage. Um, um, Doing a bronchoscopy as well. We also did the blind mini bow, went over that as well, where you can utilize the bronchoalveolar lavage with a bronchoscope, or you can do it blindly with just a catheter that extends well beyond the tip of the endotracheal tube, where you flush the 50 to 60 cc's of saline in, then aspirate those results back, and then send them off for analysis. So as we transition and move on to our optimum PEEP, if you'll think back to cardiopulmonary A and P, anatomy and physiology, or RCP 114, we had the hemodynamic case study that we went in there. We also talked about the effects of positive pressure ventilation on the pulmonary system. We also talked about that on the the cardiac system as well. Important to know your ABG values, your hemodynamic values, whether it's your CVP, your RAP, your pulmonary capillary wedge pressure, normal cardiac output values, things of the like. So those are going to be important for you to go back and review and make sure that you've got a good, consistent understanding of those so that you can apply those items to a PEEP study or PEEP titration study if you're presented with one of those on your upcoming exams. In addition to that, there's some calculated derived values such as a PF ratio. You also have your alveolar to arterial gradient. Now, I'll remind you that in order to figure out what the alveolar PO2 is, you're going to have to remember the alveolar air equation. So it's going to be important to be able to do that. The same thing with CaO2 and CVO2, the content of arterial oxygen, the content of your mixed venous oxygen. Remember, you've got formulas associated with those. So that's going to require a little bit of math as well. Uh, and then you've got your arterial to end tidal CO2 gradient that we had talked about as well. So it's going to be important, if you can recall going back to your textbook, it'll be important to remember the normal values associated with those. That way, if you're looking at a PEEP study, you can determine if those items are high or low, or what have you, and then move on from there. So we know that with the blood gas, we want our PaO2 to essentially be greater than 60 millimeters of mercury. We also understand the difference between dead space and shunt. Dead space is ventilation without perfusion. Perfusion without ventilation is dead space. Excuse me, perfusion without ventilation is shunt. So ventilation without perfusion is dead space. Perfusion without ventilation is shunt. So make sure that you have an appreciation for the difference between dead space and shunt and how those go hand in hand with our ventilation perfusion matching. So you can recall we did the Bohr equation back in RCP 114 where we were able to calculate our VDVT to look at the overall amount of dead space to tidal volume ratio and so forth as we're moving through there. So some of these other values, whether you're looking at your arterial to end tidal CO2 value, by going up on PEEP, providing more positive end expiratory pressure inside of the chest, that can have a negative impact on the cardiovascular system, the hemodynamic system. So when we're doing a PEEP titration study or trying to find the optimum PEEP level, ultimately what we're doing is trying to find a amount of positive end expiratory pressure that helps us to maximize the overall lung compliance and maximize our overall oxygenation for the patient without causing any type of over distension that would lead to any kind of barotrauma or anything of that effect, or having any type of negative um, cardiovascular effects or cardiac effects, such as a drop in or a decrease in your overall venous return, looking at a drop in our cardiac output and or blood pressure. If those items occur, it's possible that we're going to have an increase in shunting where we're not having effective ventilation perfusion matching anymore. And then we're going to get into a situation where if we're over distended because of too much positive and expiratory pressure, then we're probably going to maybe run into some issues with barotrauma and have some ventilator-induced lung injury that's going to trigger some inflammatory issues as well. And that's going to make it a little bit more difficult to uh, uh, manage those patients. So ultimately, we look at the overall goal of PEEP therapy, and we know PEEP is to help establish or reestablish our functional residual capacity or FRC. So remember your volumes, what volumes make up one lung capacities. It's also going to be important to remember that with PEEP, yes, we're wanting to increase our functional residual capacity by finding our optimum PEEP. We're going to increase our functional residual capacity, improve upon our overall lung compliance, reduce the amount of shunt, and in doing so, we should hopefully help improve our oxygenation. So you do have a series of measured values and some calculated values that we're looking at here, and it's important for you to remember those uh, moving forward. You may also look at the actual level of shunt. If you can remember the classic shunt equation or the QSQT equation, you might be tasked with calculating that in the future to help if you're looking at an overall PEEP titration study uh, or a PEEP study in general. So if we begin to look at this first series of values that we have here, so ultimately what the table itself isn't labeled well, but ultimately we go up in increments of 5 centimeters of water pressure of PEEP. So this is the PEEP in 5 centimeters of water pressure. I probably should have labeled that as such. So we go from 0 of PEEP to 5 of PEEP, 10 of PEEP, and so on, up to 25. We've got some other values that we're going to evaluate, which are arterial to end tidal CO2 value. You've got your percentage of shunt that appears as well. We're also looking at our static compliance, which is milliliters per centimeter of water pressure. We also look at our PaO2 at an FiO2 of 0.5 or 50%. And then we can also look at what our oxygen delivery is as well as we go through there. And we can see how these numbers change as we add an additional 5 centimeters of water pressure of PEEP moving through there. So ultimately what we're looking at here, if we're looking for the optimum PEEP. So this is where it's going to be important to remember those normal ranges for these items as we move through. That way we can have an appreciation for when uh, the values tend to look quite a bit better. So you know that a normal arterial to end tidal CO2 gradient roughly should be in the ballpark of about 4.5 with maybe plus or minus 2 within that. So anywhere between say 4 and 6 or maybe 2 to 6 if we're given a wide range for that. So we know that at a PEEP of 0 that's high. Um, and when that value tends to increase, um, that lets us know that the PEEP's high enough to cause maybe a drop in our overall cardiac output. We also are probably going to have an increase in shunt. We certainly can see that here with a much higher percentage of where it's supposed to be at. So we certainly can see that. So zero PEEP is not very beneficial. Gets a little bit better with PEEP of 5, but we still have a pretty wide gap there with our arterial end tidal CO2. Static compliance did improve a little bit there. The PaO2 actually got a little bit better, but our oxygen delivery uh, went down a little bit in this regard. So when we transition over here, so when we look at the rest of the values, 10 is actually our optimum peak level, and finding that our end titles, arterial to end tidal CO2 difference is 8. So it's pretty much unchanged from 10 to 15. The amount of shunt is unchanged from 10 to 15. But at 15, one of the differences here from a PEEP of 10 to a PEEP of 15 centimeters water pressure, our overall lung compliance went down. It reduced a little bit, and we're not providing as much oxygen delivery. So at a PEEP of 10, we are getting the best bang for our buck. We're getting the best oxygenation for our patient and the least amount of cardiovascular or cardiac compromise that we have. So you may see a series of different types of values, and that's just how you're going to have to go through it when you look at it. Are we having negative cardiovascular or hemodynamic side effects associated with the additional pressure inside of the chest? Has there been a significant drop in venous return? Has that resulted in a drop of cardiac output? Has our oxygen delivery gone down? Looking at those values such as shunt, PF ratios, if available, or what have you, are those increasing, decreasing? Where are we seeing the overall best bang for our buck when we go through those items? So another item that we had looked at, and this one has quite a bit more data to digest with that. Um, it does kind of take into account your PVO2, the CO2, end tidal CO2 difference, and what have you. We also begin to look at if you've calculated your alveolar air equation, the alveolar air to arterial or alveolar oxygen to arterial oxygen gradient. We also have our compliance, looking at what our PaO2 is with an FiO2 of 100%. So we see that as well, our content of arterial oxygen. So it's important to go through and make sure that you understand what those are. And then we're also calculating our oxygen transport down here with cardiac output times the arterial oxygen content. We've got our pulmonary artery pressure, pulmonary capillary wedge pressure, the arterial mixed venous oxygen difference, our cardiac output, mixed venous oxygenation. We've also got a saturation of mixed venous oxygen. We've already talked about these items here. pH that goes along with the other values that we had talked about. CO2 and CVO2 can be calculated. Static compliance can be calculated as well. And we see an overview of what our blood pressure is doing. So go through and tend to look at to see where just line by line, make sure that you're kind of taking a look at uh, how well we're doing. So if you look at here, it looks like we're spending 15 minutes each at each level of PEEP. So we go from 0 a PEEP all the way up to 30 a PEEP over the course of about 105 minutes. So if we begin to look at our blood pressure and normal blood pressure is anywhere between 120 over 80. So we begin to look over there, and we do see as we begin to go up on our PEEP levels, that blood pressure does begin to trend down just a little bit. We also see a little bit of fluctuation within our overall lung compliance as well, where it actually improved a little bit there, say between 20. I mean, it's made a little bit of improvement there, but we're getting the highest numbers of our lung compliance between 20 and 25 uh, centimeters of water pressure. PaO2 has gone up as well. So as we've gone up on our PEEP levels, the PaO2 is actually making a pretty good jump as well with each level. The arterial oxygen content, we see some improvements there as well. CO2 stayed relative, so the ventilation component of everything stayed relatively unchanged with just a fluctuation of about 2 millimeters of mercury as we went there from 37 to 39 and so on and so on. So kind of a little bit of back and forth. Same thing, our pH remained relatively unchanged as well. We start to look at that alveolar air to arterial oxygen gradient, and it does begin to reduce the higher we go with PEEP, so it trends down. Uh, so we could look at that as well. The end arterial CO2 gradient, we take a peek at that, and it's quite high at 0, quite high at 5. And remember, we said that we're within that 4.5 plus or minus 2 range. So we actually, as far as the lowest that number shows up is actually in the 25 column here. So that may be important when we come back to look at it shortly. We begin to look at the PVO2 values as well. So they're mixed venous oxygen. So remember, we're taking a reflection to an extent of how well or not so well our tissues are utilizing oxygen. And we also look at our oxygen transport or oxygen delivery down here. Um, so if we are tasked with our cardiac output as well, or assessing the uh, cardiac output fluctuates a little bit. You got the actual best number of cardiac output is here, but you can't go just off of cardiac output alone. You've got to look at the other variables that go along with that as well. So your content of arterial oxygen and venous oxygen difference moving along, pulmonary capillary wedge pressure going to give you an indication on the overall left side of the heart as well. So remember the normal values and compare those. So we see that we're getting some of the better values here. Uh, um, so we've gone to where we're now high enough to being a little too high over here. So in these three columns, we're probably getting your best pulmonary capillary wedge pressure reading that you can see there. Pulmonary artery pressure. Uh, So looking there, there's not a significant amount of change. It does begin to change. So the systolic numbers getting up into the 40s as we go a little bit higher with our PO2 and rest here. And our overall oxygen transport. Now, oxygen transport shows to be the absolute best at 25. So kind of taking a peek at all the other variables in that 25 column. Uh, Blood pressure is okay. Lung compliance is pretty good, and comparatively speaking to the other columns that we've looked at, PaO2 is 152. It's not as good as 167, but it's pretty good. At 167, our compliance actually went down by about 10 milliliters per centimeter water, and our overall systolic blood pressure went down to 90 over 65. So hemodynamically, it kind of tanked a little bit. And let's look at what the cardiac output. Cardiac output at a PEEP of 30 dropped by just about an entire liter, or actually a little bit over an entire liter. Uh, and we look at our CO2 to end tidal difference, it went back up to 15. So that's not good. So actually, we know 30 is too much. You might be torn between 20 and 25. And the deciding factor here is going to be looking at cardiac output stayed relatively the same. Your CaVO2 difference stayed relative. Pulmonary capillary wedge pressure is fairly consistent with each other. Pulmonary artery pressure is a little bit better here than it is there, but our O2 transport is quite a bit better. At 25. So looking at all of this data, 25 would be the best. And it's going to be different from patient to patient. You just got to make sure that you understand what each of these values over here, what their normal values are, if they increase, if they decrease, what that tends to indicate, and then apply that knowledge to looking at the overall PEEP titration study. So again, we went over VAP this week. We're going to go over next week sedatives, analgesics, paralytics, and some of our inhaled agents. We'll also begin to look at some of the extrapulmonary effects of mechanical ventilation also. Uh, so that is going to take care of us from week 6, so a review of week 6 and 5. Thank you all for your time and attention. I hope you have a good day.